This is Chapter 14 of the ATI nutrition book, Gastrointestinal Disorders. Nurses need to have an awareness of nutritional needs for clients who have gastrointestinal disorders. It is important to explore dietary needs with the client and recommend modifications and relationships to the disease process. Understanding the role of primary and secondary prevention is essential to successful treatment. Nutrition therapy for gastrointestinal disorders is generally aimed at minimizing or preventing manifestations, in some conditions, celiac disease. Nutrition is the only treatment. For some GI disorders, nutrition therapy is the foundation of treatment. Assessment and data collection. Determine whether the client is experiencing any of the following. Difficulty chewing or swallowing, nausea, vomiting or diarrhea, bloating, excessive flatus, occult blood, steatorrhea, abdominal pain or cramping, abdominal distension, pale, sticky bowel movements, changes in weight, eating patterns, or bowel habits. Determine whether the client uses the following: tobacco, alcohol, caffeine, over-the-counter medications to treat GI conditions. Many have GI complications or be contraindicated with GI conditions. Nutritional supplements, herbal supplements for GI conditions or other problems. Some clients do not consider them to be medications, so they do not mention them to the provider. Nutritional guidelines and nursing interventions. General gastrointestinal considerations. Monitor gastrointestinal parameters, weight and weight changes, laboratory values, elimination patterns, I&O. Low fiber diet. Avoid foods that are high in residue content, whole grain breads and cereals, raw fruits and vegetables. Diets low in fiber reduce the frequency and volume of fecal output and slow transit time of food through the digestive tract. Low fiber diets are used short-term for clients who have diarrhea or malabsorption syndromes. High fiber diets focus on foods containing more than 5 grams of fiber per serving. A diet high in fiber helps increase stool bulk, stimulate peristalsis, prevent constipation, and protects against colon cancer. Nausea and vomiting. Potential causes of nausea and vomiting include decreased gastric acid secretion, decreased gastrointestinal motility, allergy to foods, bacterial or viral infection, and increased intracranial pressure, liver, pancreatic, and gallbladder disorders, and adverse effects of some medications. The underlying cause of nausea and vomiting should be investigated. Assessing the appearance of the emesis will aid in diagnosis and treatment. Coffee ground emesis indicates the presence of blood. Pale green indicates bile. Once manifestations subside, begin with clear liquids followed by full liquids, and advance the diet as tolerated. Easy to digest, low-fat carbohydrate foods such as crackers, toast, oatmeal, pretzels, plain bread, bland fruit are usually well tolerated. Nursing actions. Promote good oral hygiene with toothbrushing, mouth swabs, mouthwash, and ice chips. Elevate the head of the bed. Serve foods at room temperature or chilled. Client education. Avoid hot and spicy foods. Avoid liquids with meals as they promote a feeling of fullness. Avoid high-fat foods if they contribute to nausea because they are difficult to digest. Anorexia. Anorexia is defined as a lack of appetite. It is a common finding for numerous physical conditions and is an adverse effect of certain medications. It is not the same as anorexia nervosa. Anorexia can lead to decreased nutritional intake and subsequent protein and calorie deficits. Nursing actions. Decrease stress at mealtimes. Collect data regarding adverse effects of medicines. Administer medications to stimulate appetite. Assess and modify environment for unpleasant odors. Remove items that cause a decrease in appetite. Soiled linens, garbage, emesis basins, bedpans used, tissues, clutter. Assess and manage anxiety and depression. Provide small, frequent meals and avoid high-fat foods to help maximize intake. Beverages should be held at least 30 minutes before and after meals to prevent the client from feeling full before adequate intake of calories from food. Provide liquid supplements between meals to improve protein and calorie intake. Ensure that meals appear appealing. Serve larger meals early in the day. Season food according to taste for decreased ability to taste. Enhance foods with tart, orange juice, lemon juice, or strong seasonings, basil or oregano. Assess for changes in bile status, increased gastric emptying, constipation, diarrhea. Position to increase gastric motility. Provide mouth care before and after meals. Constipation. Clients who have constipation have difficult or infrequent passage of stools, which can be hard and dry. Causes include irregular bowel habits, psychogenic factors, inactivity, chronic laxative use, obstruction medications, GI disorders. This is irritable bowel syndrome or IBS, pregnancy or secondary to genital rectal trauma, sexual abuse or childbirth, and inadequate consumption of fiber and fluid. Encourage exercise and a diet high in fiber, which is 25 grams a day for females and 38 grams a day for males, and promote adequate fluid intake to help alleviate constipation. If caused by medicine, a change in the medication might be necessary. Nursing actions. Determine onset and duration of past and present elimination patterns, what is normal for the client, activity levels, occupation, dietary intake, and stress levels. Collect data about past medical and surgical history, medication use, OTC, herbal supplements, laxative, enemas, and prescriptions, presence of rectal pressure or fullness, and abdominal pain. Encourage client to gradually increase daily intake of fiber. Client education. Increase fluid intake to 64 ounces a day unless contraindicated. An increase in fiber intake is the preferred treatment for constipation. Avoid chronic use of laxatives. Diarrhea. Diarrhea can cause significant losses of potassium, sodium, and fluid, as well as nutritional complications. Common causes of diarrhea include emotional and physical stress, gastrointestinal disorders, malabsorption disorders, infections, and certain medications. Low-fiber diets might be recommended on a short-term basis to decrease bowel stimulation. Nutrition therapies varies with the severity and duration of diarrhea. A liberal fluid intake to replace losses is needed. Dysphagia. Dysphagia is an alternation in the client's ability to swallow. Causes include obstruction, inflammation, and certain neurologic disorders. Modifying the texture of foods and the consistency of liquids can enable the client to achieve proper nutrition. Dry mouth can contribute to dysphagia. Evaluate medications being taken to determine if this is a potential adverse effect. Clients who have dysphagia should be referred to a speech therapist for evaluation. Dietary modifications are based on the specific swallowing limitations experienced by the client. Nutritional supplements are beneficial if nutritional intake is deemed inadequate. Nursing actions. Clients who have dysphagia are at an increased risk for aspiration. Place the client in an upright or high Fowler's position to facilitate swallowing. Provide oral care prior to eating to enhance the client's sense of taste. Allow adequate time for eating, use adaptive eating devices, and encourage small bites and thorough chewing. Client education. Pills should be taken with at least 8 ounces of fluid, can be thickened to prevent medication from remaining in the esophagus. Avoid thin liquids and sticky foods. Dumping syndrome. Normally, the stomach controls the rate in which nutrients enter the small intestine. When a portion of the stomach is surgically removed, the contents of the stomach are rapidly emptied into the small intestine, causing dumping syndrome. Early manifestations typically occur 10 to 20 minutes after eating. Early manifestations include a sensation of fullness, abdominal cramping, nausea, diarrhea, and vasomotor manifestations, faintness, syncope, diaphoresis, tachycardia, hypotension, and flushing. Late manifestations occur 1 to 3 hours after eating. Late manifestations include diaphoresis, weakness, tremors, anxiety, nausea, and hunger. Manifestations resolve after intestine is emptied. However, there is a rapid rise in blood glucose and increase in insulin levels immediately after the intestine empties. This leads to hypoglycemia. Nursing actions. Monitor clients receiving enteral tube feedings and report manifestations of dumping syndrome to the provider. Monitor the client for vitamin and mineral deficits, iron and vitamin B12. Client education. Consume small, frequent meals. Consume protein and fat at each meal. Avoid food that contains concentrated sugars and restrict lactose intake. Plan to consume liquids in 1 hour after meals or between meals, no sooner than 30 minutes after eating. Lie down after meals to delay gastric emptying. If reflux is a problem, try a reclining position. Gastroesophageal reflux disease. Gastroesophageal reflux disease, or GERD, occurs as the result of the abnormal reflux of gastric secretions up the esophagus. This leads to indigestion and heartburn. Factors that contribute to GERD include hiatal hernia, obesity, pregnancy, smoking, some medications, and genetics. Long-term GERD can cause serious complications, including adenocarcinoma of the esophagus and Barrett's esophagus. Manifestations include heartburn, retrosternal burning, painful swallowing, dyspepsia, regurgitation, coughing, hoarseness, and epigastric pain. Pain can be mistaken for a myocardial infarction. Client education. Avoid situations that lead to increased abdominal pressure, such as wearing tight-fitting clothing. Avoid eating for 3 hours before lying down. Elevate the body on pillows instead of lying flat, and avoid large meals at bedtime and snacks. Attempt weight loss if overweight or obese. Avoid trigger foods such as citrus fruits and juices, spicy foods, and carbonated beverages. Avoid items that reduce lower esophageal sphincter pressure like fatty foods, caffeine, chocolate, alcohol, cigarette smoke, all nicotine products, peppermint, and spearmint flavors. Acute and chronic gastritis. Gastritis is characterized by inflammation of the gastric mucosa. The gastric mucosa is congested with blood and fluid becoming inflamed. There is a decrease in acid produced and an overabundance of mucus. Superficial ulcers occur, sometimes leading to hemorrhages. Acute gastritis occurs as gastritis occurs with excessive use of non-steroidal anti-inflammatory drugs, or NSAIDs. Bile reflux, ingestion of small acid or alkali substance as a complication of radiation therapy or as a complication of trauma, burns, food poisoning, severe infection, liver, kidney, or respiratory failure, major surgery. Chronic gastritis occurs in the presence of ulcers, benign or malignant, Helicobacter pylori, autoimmune disorders like pernicious anemia, poor diet like excessive caffeine, excessive alcohol intake, medications like alendronate and perindopril, and reflux of pancreatic secretions and bile into stomach. Manifestations include abdominal pain or discomfort, can be relieved by eating. Headache, lethargy, nausea, anorexia, hiccuping, lasting a few hours to days, heartburn after eating, belching, sour taste in mouth, vomiting, bleeding, and hematemesis, vomiting of blood. Acute recovery typically occurs in 1 day, but can take 2 to 3 days. The client should eat a bland diet when able to tolerate food. IV fluid replacement therapy is indicated if the condition persists. When the condition occurs due to ingestion of strong acids or alkalis, dilution and neutralization of the causal agent is needed. Avoid lavage and emetics due to potential perforation and esophageal damage. Chronic management. Modify diet, reduce and manage stress, avoid alcohol and NSAIDs. If condition is persistent, the provider will prescribe an H2 receptor antagonist, which is famotidine. Nursing actions. Monitor for vitamin deficiency, especially of vitamin B12. Client education. Avoid eating frequent meals and snacks as they promote increased gastric acid secretion. Avoid alcohol, cigarette smoking, aspirin, and other NSAIDs, coffee, black pepper, spicy foods, and caffeine. Peptic ulcer disease, or PUD, is characterized by an erosion of the mucosal layer of the stomach or duodenum. This can be caused by bacterial infection with H. pylori or the chronic use of NSAIDs like aspirin and ibuprofen. Some clients who have PUD do not experience manifestations. Others report dull, gnawing pain, burning sensation in the back or low mid-epigastric area, heartburn, constipation or diarrhea, sour taste in mouth, burping, nausea, vomiting, bloating, urea present in breath, and tarry stools. Eating can temporarily relieve pain. Anemia can occur due to blood loss. For PUD caused by H. pylori, the provider prescribes triple therapy, a combination of antibiotics and acid-reducing medications, to be taken for 10 to 14 days. Client education. Avoid coffee, alcohol, caffeine, aspirin, and other NSAIDs, cigarette smoking, black pepper, and spicy foods. Lactose intolerance. Lactose intolerance results from an inadequate supply of lactase in the intestine, the enzyme that digests lactose. The enzyme that converts lactose into glucose, and galactose is absent or insufficient. Manifestations include distension, cramps, flatus, and osmotic diarrhea. Small amounts, 4 to 6 ounces of milk taken during meals, can be tolerated. Some dairy products, such as yogurt and aged cheeses, are low in lactase and can be better tolerated. Nursing actions: monitor for vitamin D and calcium deficiency. Client education: avoid or limit intake of foods high in lactose, such as milk, soft cheese, ice cream, cream soups, sour cream, puddings, and coffee creamer. Ask the provider about the use of a lactase enzyme. Ileostomies and colostomies. An ostomy is a surgically created opening on the surface of the abdomen from either the end of the small intestine, ileostomy, or from the colon, colostomy. Fluid and electrolyte maintenance is the primary concern for clients who have ileostomies and colostomies. The colon absorbs large amounts of fluid, sodium, and potassium. Nutrition therapy begins with liquids only and is slowly advanced based upon client tolerance. Nursing actions: provide emotional support to clients due to the risk of altered body image. Client education: consume a diet that is high in fluids, at least 1.9 to 2.4 liters, 64 to 80 ounces per day, and soluble fiber. Avoid foods that cause gas, like beans, eggs, carbonated beverages, stomal blockages like nuts, raw carrots, and popcorn, and foods that produce odor, like eggs, fish, and garlic. Increase intake of calories and protein to promote healing of the stoma site. Diverticulosis and diverticulitis. Diverticula are pouches protruding through the muscle of the intestinal wall, usually from increased intraluminal pressure. They occur anywhere in the colon, but usually in the sigmoid colon. Unless infection occurs, diverticula causes no problems. Diverticulosis is a condition characterized by the presence of diverticula. Diverticulitis is inflammation that occurs when fecal matter becomes trapped in the diverticula. Manifestations of diverticulitis include abdominal pain, nausea, vomiting, constipation or diarrhea, and fever accompanied by chills and tachycardia. The client receives antibiotics, anticholinergics, and analgesics. Clients who have severe manifestations are admitted to the hospital, and dehydration is treated with IV therapy. Opioid analgesics are administered for pain. Complications such as periodontitis, bowel obstruction, abscess can warrant surgical intervention. A high-fiber diet can prevent diverticulosis and diverticulitis by producing stools that are easily passed, thus decreasing pressure within the colon. During acute diverticulitis, a clear liquid diet is prescribed until inflammation decreases, then a higher-fiber, low-fat diet is indicated. Clients require instruction regarding diet adjustments based on the need for an acute intervention or preventative approach. Inflammatory bowel disease, or IBD. Crohn's disease, which is regional enteritis, and ulcerative colitis are chronic, inflammatory bowel diseases characterized by periods of exacerbation and remission. Manifestations include nausea, vomiting, abdominal cramps, fever, fatigue, anorexia, weight loss, steatorrhea, and low-grade fever. Nutrition therapy is focused on providing nutrients in forms that the client can tolerate. A low-residue, high-protein, high-calorie diet with vitamin and mineral supplementation is prescribed during exacerbation to minimize bowel stimulation. Fluid and electrolyte imbalances are corrected with IV fluids and oral replacement fluids. Enteral nutrition can be prescribed during exacerbations, especially if the client is reluctant to eat. Because parenteral nutrition is more costly with a relatively similar benefit, it is not used unless enteral nutrition is ineffective or contraindicated. When the client is not experiencing an exacerbation, the diet can be broadened based on the client's specific disease process and triggers. Additional therapy. Complementary therapies including vitamin C and herbs, flaxseed, yoga, hypnosis and breathing exercises, sedatives, anti-diarrhea and anti-peristaltic agents, aminocyclate medications, and corticosteroids to reduce inflammation, immunomodulators to alter the immune response and prevent relapse, surgery when treatments are not effective, client education. Avoid intake of substances that cause or exacerbate diarrhea and avoid nicotine. Cholecystitis. Cholecystitis is characterized by inflammation of the gallbladder. The gallbladder stores and releases bile that aids in the digestion of fats. Manifestations include pain, tenderness, and rigidity in upper tight abdomen. Pain can radiate to the right shoulder or mid-sternal area. Nausea and vomiting and anorexia can also occur. If the gallbladder becomes filled with pus or becomes gangrenous, perforation can result. In clients who have large stones or inability to control the condition with diet modifications, surgery is required. Pancreatitis and liver involvement can result from uncontrolled cholecystitis. Fat intake should be limited to reduce stimulation of the gallbladder. The diet is individualized to the client's need and tolerance. Pancreatitis. Pancreatitis is an inflammation of the pancreas, which can be acute or chronic. In 70% of the acute cases, alcohol use and gallstones are major causes. Chronic pancreatitis can result from acute pancreatitis that does not resolve. The pancreas is responsible for secreting enzymes needed to digest fats, carbohydrates, and proteins. Nutritional therapy for acute pancreatitis involves reducing pancreatic stimulation. The client is prescribed nothing by mouth, and a nasogastric tube is inserted to suction gastric contents. TPN can be used until oral intake is resumed. Nutritional therapy for chronic pancreatitis usually includes a low-fat, high-protein, and high-carbohydrate diet. It can include providing supplements of vitamin C and B complex vitamins. Liver disease. The liver is involved in the metabolism of most nutrients. Disorders affecting the liver include cirrhosis, hepatitis, and cancer. Malnutrition is common with liver disease. Protein needs are increased to promote a positive nitrogen balance and prevent a breakdown of the body's protein stores. Carbohydrates are generally not restricted as they are an important source of calories. Caloric requirements might need to be increased based on an evaluation of the client's stage of disease, weight, and general health status. Multivitamins, especially vitamins B, C, and K, and mineral supplements might be necessary. Alcohol, nicotine, and caffeine should be eliminated. Celiac disease. Celiac disease is also known as gluten-sensitive enteropathy, celiac spur, and gluten intolerance. It is a chronic inherited genetic disorder with autoimmune characteristics. Clients who have celiac disease are unable to digest the protein gluten. They lack the digestive enzyme DPP-IV, which is required to break down the gluten into molecules small enough to be used by the body. In celiac disease, gluten is broken down into peptide strands instead of molecules. The body is not able to metabolize the peptides. If untreated, the client will suffer destruction of the via and the walls of the small intestine. Celiac disease can go undiagnosed in both children and adults. Manifestations vary widely. Children who have celiac disease have diarrhea, stratorrhea, anemia, abdominal distension, impaired growth, lack of appetite, and fatigue. Typical manifestations in adults include diarrhea, abdominal pain, bloating, anemia, stratorrhea, and osteomalacia. Treatment for celiac disease is limited to avoiding gluten. However, eliminating gluten, which is found in wheat, rye, and barley, is difficult because it's found in many prepared foods. Clients must read food labels carefully in order to adhere to a gluten-free diet. Some gluten-free products are unappealing to clients, and many are more expensive than other products. Prognosis is good for clients who adhere to a gluten-free diet. Nursing actions. Monitor for complications including bleeding or bruising due to inadequate vitamin K intake, manifestations of anemia, iron, folate, vitamin B12, and manifestations of osteoporosis. Collaborate with the dietitian to assist with food selection and label reading. Client education. Eat foods that are gluten-free: milk, cheese, rice, corn, eggs, potatoes, fruit, vegetables, fresh meats, and fish, dried beans. Read labels on processed products. Gravy mixes, sauces, cold cuts, soups, and many other products have gluten as an ingredient. Read labels and research non-food products like lipstick, communion wafers, vitamin supplements, which also have gluten as an ingredient. A nurse is teaching a client who has constipation about a high-fiber, low-fat diet. Which of the following food choices by the client indicates understanding of the teaching? Brown rice. A nurse is assessing a client who is post-operative from a gastric bypass and who just finished eating a meal. Which of the following findings are manifestations of dumping syndrome? Dizziness, hypotension, and diarrhea. A nurse is collecting data from a client who has peptic ulcer disease. Which of the following findings should the nurse expect? anemia, tarry stools, and epigastric pain. A nurse is reviewing information about following a low-fat diet with a client who is recovering from pancreatitis. Which of the following foods should a nurse recommend? Oatmeal, canned peaches, and pretzels. A nurse is instructing a client who has celiac disease about foods to avoid. Which of the following foods should the nurse include in the teaching? Graham crackers.